Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Today the lecture is under the concept of tuberculous CNS infection. The Mycobacterium tuberculosis is one of the most common infectious agents in the world. The Mycobacterium tuberculosis central nervous system infection affect all ages. The incidence has increased. The Mycobacterium tuberculosis, and it is an aerobic gram-positive acid-fast pleomorphic bacilli, and it is an intracellular pathogen that survives within the host macrophages. Pathology and pathogenesis. The tuberculous central nervous system infection usually results from reactivation of the latent infection with Mycobacterium TB, which is an acid-fast bacilli. It is passed between persons through respiratory droplets. Mycobacteria multiply in the alveolar space, and within 2 to 4 weeks, hematogenous spread from the primary lesion to the extrapulmonary sites occurs, but it can be a result of seeding through the bloodstream from a site of chronic infection. TB of the CNS develops most commonly shortly after a primary infection in children and adolescents or as a part of miliary TB. So there will be small caseous microtubules develop in the brain meninges, skull or vertebrae close to the meninges in the course of the primary infection. Here the organism remains in a dormant state in tubercles. The tuberculous meningitis results from rupture of a subependymal microtubercles discharging tuberculoprotein and mycobacteria into the subarachnoid space, but the deeper tubercles may enlarge and become what is called tuberculomas. Subacute inflammation in the subarachnoid space, especially of the basal meninges, then develop, and then a thick oxidate forms following first cranial nerve lesion, cerebral arteritis causing infarction, impairment of cerebrospinal fluid absorption or obstruction of the CSF circulation causing hydrocephalus. Mycobacterial infection may involve the spinal cord, either as spinal arachnoiditis producing radiculopathy or myelopathy, extradural compression from a tuberculoma or vertebral bone infection. Tuberculous spondylitis may result in an epidural abscess. Usually the thoracic cord is the most common site of the spinal cord which is affected, so arteritis or end arteritis of anterior spinal artery can lead to infarction at that territory. Mycobacterium tuberculosis central nervous system infection take a variety of forms, include subacute meningitis. So the patient here will be presented with symptoms of meningitis. Symptoms of constitutional symptoms. 2 weeks of low-grade fever, night sweat, non-specific malaise, irritability, insomnia, lethargy, anorexia, headache, abdominal pain, vomiting, and behavioral changes. During the second stage, there are meningeal irritation signs, focal neurological signs such as hemiparesis, hemianesthesia, aphasia, and hemanopia resulting from cerebral infarction caused by end arteritis. Second form is acute fulminant meningoencephalitis. Third, tuberculoma, a large caseous tubercle. The patient may present with constitutional symptoms plus the manifestation of space-occupying lesion. And 4, tuberculous encephalopathy, which is tuberculous infection. It should be suspected in any patient with acute or subacute confusional state. Fluid and electrolyte and acid-base disturbances are common in TB meningitis. The result of vomiting inadequate fluid intake and the syndrome. This result of vomiting, inadequate fluid intake, and the syndrome of inappropriate secretion of antidiuretic hormone. Diagnosis: because of a variety of presenting forms and the difficulty in diagnosis, high index of suspicion should be maintained. Examination of the cerebrospinal fluid is crucial. Its opening pressure is raised in most patients, but may be low in those developing block from spinal arachnoiditis. The CSF appears clear or slightly turbid, but may form a spiderweb clot on standing. Lymphocytic pleocytosis. The glucose concentration in cerebrospinal fluid is low. Tubercle bacilli can be detected in CSF in up to 20% of cases and more in those with a clot. This figure decreased in children. Culture of mycobacteria is successful in 10 to 90% of cases. The genome of Mycobacterium tuberculosis can be detected in cerebrospinal fluid by PCR, polymerase chain reaction. A new tests which are introduced for diagnosis of TB, like GeneXpert test, which is a machine that can detect Mycobacterium tuberculosis TB in a sample of sputum or CSF. And the second new investigation is the IGRA, is a blood test used to diagnose TB infection. A neuroimaging study are useful in detecting tuberculoma, cerebral infarction, and hydrocephalus. Differential diagnosis: first, partially treated bacterial meningitis. Second, neoplastic and granulomatous infiltrations of the meninges, for example, carcinomas, leukemias, lymphomas, and fungal infections. Treatment: first-line antituberculous medications include rifampicin, isoniazid, pyrazinamide, ethambutol, the abbreviation RIPE, with streptomycin. The treatment divided into two phases: an intensive initial phase and a continuation phase. In the intensive phase, therapy include the four first-line medications, and it continues for 2 months. In the continuation phase, the treatment regime is reduced to 2 medications, isoniazid and rifampicin, and the continuation phase is usually extended to total treatment periods of 12 months. Trial of chemotherapy is justified when there is a clinical suspicion of tuberculous central nervous system infection, particularly when the diagnostic facilities are limited. The tuberculomas usually respond very slowly to anti-TB drugs, and it usually takes at least 24 months or longer for lesions to disappear. The corticosteroid used routinely because it is significantly reduced death and disabling residual neurological deficit among survivors. The raised intracranial pressure from hydrocephalus can be treated conservatively with acetazolamide, with or without furosemide and corticosteroid. Within the first 4 to 6 weeks of treatment, the CSF pressure of the majority of the patients return to normal and the edema disappear. If these measures fails, so surgical shunting will be needed. Prognosis: the untreated mortality of tuberculous meningitis is close to 100%. Complete recovery is the rule if the treatment is started before the appearance of focal signs or stupor. There are permanent complications in 10 to 30% of survivors, like intellectual impairment, recurrent seizure, blindness, deafness, sequence, and residual motor deficit. The mortality is about 15 to 30% in Western countries and between 30 and 50% in developing countries. There are permanent complications in 10 to 30% of survivors, Coma at the time of presentation is the most significant predictor for poor prognosis. Now, viral encephalitis, definition and distinction to meningitis, where the infectious process and associated inflammatory response is limited largely to the meninges. In encephalitis, the brain parenchyma is also involved. Many patients with encephalitis also have evidence of associated meningitis, so the term will be meningoencephalitis, and in some cases involvement of the spinal cord or nerve roots, cephalomyelitis, cephalomyeloradiculitis, respectively. Etiology. The clues that suggest a specific virus include the time of year, the recent travel, the contact with insects or other animals, sexual contacts, and immune suppression. The most important viruses causing sporadic cases of encephalitis in immune-competent adults are herpes virus type 1, varicella zoster virus, and enteroviruses. Epidemics of encephalitis are caused by arbovirus, an immune-deficient patient with depressed cell-mediated immunity, Hodgkin disease, so they may develop herpes zoster encephalitis. Clinical manifestation. In addition to the acute febrile illness with evidence of meningeal involvement, characteristic of meningitis, the patient with encephalitis commonly has a triad. First, an altered level of consciousness. Second, seizure. Third, evidence of either focal or diffuse neurological signs or symptoms. Features of viremia include lymphadenopathy and pharyngitis. Laboratory diagnosis. The CSF examination should be performed in all patients with suspected viral encephalitis, unless contraindicated by the presence of severely increased intracranial pressure. The characteristic CSF profile consists of lymphocytic pleocytosis, mildly elevated protein level, normal glucose level, and about 20% of patients with encephalitis will have a significant number of red blood cells in the CSF in an anatraumatic tab called xanthochromia. CSF polymerase chain reaction. The polymerase chain reaction amplify DNA from the CSF, become the diagnostic procedure of choice for many types of viral encephalitis. The treatment. The basic management and supportive therapy should include careful monitoring of intracranial pressure, fluid restriction and avoidance of hypotonic intravenous solutions, suppression of fever, and the seizures should be treated with standard anticonvulsant regimen. Now, herpes simplex encephalitis. This is the commonest and gravest form of acute encephalitis. It occurs sporadically throughout the year and in patients of all ages and in all parts of the world, and is due to almost always to herpes simplex virus type 1. Pathology. The lesion takes the form of intense hemorrhagic necrosis of the inferior and the medial parts of the temporal lobes and the orbital parts of the frontal lobes. The temporal lobe lesions are usually bilateral. But need not to be symmetrical. This distribution of lesions is so characteristic. Clinical features. The symptoms, which evolve over several days, are in most cases like those of any other acute encephalitis, namely fever, headache, seizures, confusion, stupor, and coma. Active herpes labialis occasionally seen, but not reliably implicate a herpes simplex virus as a cause of encephalitis. Other manifestations include olfactory or gustatory hallucinations, anosmia, temporal lobe seizures, a brief period of personality change, bizarre or psychotic behavior, aphasia, and hemiparesis. Differential diagnosis: cerebral vasculitis, brain abscess, TB, meningitis, varicella zoster viral encephalitis, and autoimmune limbic encephalitis. Diagnosis. The diagnosis may be difficult. acute herpes simplex encephalitis must be distinguished from other types of viral encephalitis. CSF examination. The CSF is often under increased pressure and almost invariably shows a lymphocytic pleocytosis. Often there are few red cells. The protein content is increased in most cases. Rarely, the CSF glucose level may be reduced to slightly less than 40 mg per deciliter. The EEG changes. And the temporal regions are suggestive, though not specific for the disease. CT and MRI show the affected areas with surrounding edema and sometimes with scattered areas of hemorrhage occupying the inferior parts of the frontal and temporal lobes. The application of the polymerase chain reaction to amplify DNA from the CSF are proving to be useful in diagnosis in first few days of illness, while the virus is replicating and enable one to avoid brain biopsy. The only other absolute way to establish the diagnosis of acute herpes simplex viral encephalitis is by fluorescence antibody study and by viral culture of the cerebral tissue obtained by brain biopsy. Treatment. Acyclovir is given intravenously in dosage of 30 to 45 mg per kg per day and continued for 14 to 21 days in order to prevent relapse. The main problem with the acyclovir are local irritation of the veins used for infusion, mild elevation of hepatic enzyme, or transient impairment of renal function. Prognosis is influenced by the patient's age and level of consciousness at presentation and by the treatment. Now, subacute sclerosing panencephalitis, SSPE. It is a chronic non-permissive infection of brain tissue with the measles virus. The most patients give a history of primary measles infection at an early age, like 2 years, which is followed after a latent interval of 6 to 8 years by the development of progressive neurological disorder. Clinical manifestation. The initial manifestations include progressive psychomotor retardation like poor school performance and mood and personality changes. Typical signs of CNS viral infections including fever and headache do not occur. As the disease progresses, patients develop progressive intellectual deterioration, focal and or generalized seizures, myoclonus, cerebellar ataxia, and visual disturbances. In the later stage of the illness, patients develop disturbance of level of consciousness and spastic quadriparesis. Diagnostic studies. MRI. It is usually early normal, although areas of white matter lesions in the brain and the brainstem appear as the disease progresses. CSF, it is usually acellular, mean no cells, no elevation of cells, mild protein elevation and marked IgG, immunoglobulin elevation, with elevation of anti-measles antibody. Viral antigen and viral genome can be detected by PCR. EEG, there is a characteristic periodic changes followed by periods of attenuated flat background. Treatment. There is no definitive therapy for SSPE is available. Treatment with isoprenosine alone or in combination with intrathecal or intraventricular alpha interferon has been reported to prolong survival and to produce clinical improvement in some patients. Lastly, we will talk about the fungal meningitis briefly. The fungal meningitis is a rare infection in immune-competent patients, but it remains a significant cause of morbidity and mortality in immune-compromised, elderly, patients with cancer. The cryptococcal meningitis is the most common form of fungal meningitis, but there are dozens of fungi that can cause meningitis. Certain geographic areas have a higher incidence of certain forms of fungal meningitis based on the relatively higher concentrations of the organism in those areas. Epidemiology. Cryptococcal meningitis comprise 4 to 8% of all forms of meningitis in elderly or patients with cancer. Clinical manifestation. Patients with fungal meningitis often present with subacute course of headache and meningeal irritation signs with or without fever. The most important factor in diagnosing fungal meningitis is suspecting it. The laboratory studies, the combination of lymphocytic predominance on CSF cell counts and normal to mildly low glucose suggests an bacterial and possibly fungal etiology. An India ink stain can be helpful in identifying the cryptococcal meningitis, but it has low sensitivity. Serum and CSF antigens and antibodies to specific organisms can confirm a diagnosis if positive, but do not rule out fungal meningitis if negative. Treatment. The treatment of fungal meningitis must balance the morbidity from the organism against the toxicity of the medications. The fungal infections usually respond well to amphotericin B plus flucytosine for at least 4 weeks. Therapy should be extended for a total of 6 weeks. In the patient with neurological complications, induction therapy is followed by consolidation therapy with fluconazole. Prognosis. Because of majority of patients that get fungal meningitis are immune compromised, patients' underlying comorbid states, the patient underlying comorbidities dramatically affect the patient outcome. Certain factors such as hydrocephalus, altered mental states, and an elevated CSF pressure increase the risk of an unfavorable outcome. Thank you.